President and CEO of the National Hispanic Medical Association. And today we're joined by a great group of speakers. I'll introduce them all in a minute. We have a title of Aging with HIV, Surviving Another Pandemic in the Latino Community. We want to thank our partners, the International Association of Providers of AIDS Care, the Area Agency on Aging in Region 1, and the WAL Las Memorias. Our speakers, we have Dr. Douglas Drevets, Chief of Infectious Diseases from the University of Oklahoma College of Medicine, Dr. Chris Duncombe, Chief Medical Officer for the International Association of Providers of AIDS Care, Dr. Peralta, President and CEO of Casa Ruben, Inc., fellow Massachusetts Institute of Technology, Ms. TeKampe, Program Director of HIV Care Directions for Region 1 Area Agency on Aging, and Mr. Zaldivar, Richard Zaldivar, CEO and founder of the WAL Las Memorias project from Los Angeles. So we've got a national group of experts. So thank you all for joining us today with the National Hispanic Medical Association. We are supported by Centers for Disease Control and have been for 6 years now on educating our networks as well as the public on the importance of HIV for the Latino community and other underserved communities. We have some housekeeping. Presentations will be followed by Q&A. And we'd like you to type questions in the Q&A box at the bottom. And recording and slides will be available next week at our website, which is NHMA-MD.org. And again, want to thank everybody for being here. So our first speaker, Dr. Drevets, you want to take it away?
Sure. Thank you very much for inviting me to participate in this astute panel, and I really appreciate the opportunity to speak with everybody about this topic. So Sophie and I will be tag teaming the slides, so you'll hear me say next or tap periodically. So can we have the next slide, please? So this shows you why we are having this webinar. It's a global data from UNAIDS, and it shows that there's been this astounding increase in numbers of people over the age of 50 who are living with HIV. Next slide, please. And not only global, it's also here in the US. And this is a county level picture of the US with showing individuals and the rates of individuals aged over 55 who live with HIV. And as you can see, the largest proportion of those individuals is located along the eastern and the southern seaboards, and then of course along the west. And overall, about 35% of individuals in the US who are living with HIV are over the age of 55. Next, please. Next. And not only is it global and national, it's also very local for us here in Oklahoma City. These are data from our Ryan White funded clinic that we call the Infectious Disease Institute. And it shows that over a 10-year comparison, individuals over the age of 50 have become our single largest demographic of folks that we care for here in Oklahoma City. And so this is not really some abstract notion for me. It's something that I see every time I go to clinic. Next, please. So what I'll be talking about just in the time that I have are several topics. The first of all is looking at the key drivers of the demographic shift from younger to older. I will talk a little bit about some of the obvious consequences of aging with HIV, and then I will finish off on some not so obvious consequences of aging with HIV. Next, please. So to start with, this is probably a graphic that you all have seen. It shows the deaths per 100,000 persons in the US from 1987. And you can see that from 87 to roughly 95, there is this huge increase in the numbers of deaths. Could you tap motion, please? And this was because we really had relatively few effective therapies. shows that during that time, we only had 4 antiretrovirals, and we didn't really know how to use them quite well. We started out with monotherapy, and then dual therapy with AZT and DDI was considered an advance. But during this time, nothing really helped to change the trajectory of the HIV replication in everybody. Next, please. But then that all changed in about 95, 96, and that coincided with development of the protease inhibitors and the NNRTIs. And it was a powerful effect. And I remember living through this, and it was just incredible that now we could take individuals who in the early 90s and the late 70s had roughly on average a 12-month life expectancy, to where we could start shifting that towards many times that. Next, please. And now, as you can see, the medications have just come out sort of in droves. We have new ones, new classes sometimes every year, every other year. And the life expectancy and death rates just keep improving with time. Next, please. Importantly, when you look across race and ethnicity, the gains in survival were distributed across all races and all ethnicities. As you can see, the Black African-American demographic was among the hardest hit initially, and yet they also had a tremendous drop in the death rates back in the 90s. Similarly, with the Hispanic Latino community, there was also a disproportionately high death rate, but also strong gains in the response to antiretroviral therapy. Next, please. And this also happened across the world. The shift started a little bit later, and I believe this coincided largely with PEPFAR and some other large projects to disseminate antiretroviral therapy across the world. But as you can see in this graphic, there has been a steady drop in the numbers of deaths caused by AIDS per year. And of course, this is multifactorial, but antiretroviral therapy is certainly a key to this. Next, please. The second thing that I think is driving the demographic shift from younger to older individuals with HIV are new diagnoses. And in the United States in 2018, there were just under 38,000 new cases of HIV diagnosed. 10% of those were in individuals over the age of 55. Next, please. When you look specifically at the Latino community, about a third of those new diagnoses were in Latinos, with just over 10,000 new diagnoses in the Latino community. Next, please. And within this group, just under 10%, so about 7%, 7.5% of Latinos were diagnosed over the age of 55. Next, please. And not only is this just a factoid to let you know, it's important in part because, as you can see on this graph over on the far right, this represented an increasing demographic in the Latino community that was up the highest amount of 12% compared with others that were either down or up a little bit less. So this is something that is going across or happening in many different areas of the US and across ethnicities. Next, please. And it's important to know this because individuals who are diagnosed over the age of 55 tend to have a late diagnosis. Next, please. This graphic shows you the proportion of individuals who are diagnosed with HIV who have a late diagnosis. And this specifically means that they are diagnosed with AIDS within 3 months of the HIV diagnosis. And you can clearly see that those aged over 55 have the highest group, as a group, are the highest with a late HIV diagnosis, in part suggesting that we just don't test this group enough. Next, please. The good side of things is that when you look at the proportion that are virally suppressed, next, please, you can see that those who are age 55, once they are plugged into care and do get on antiretroviral therapy, clearly do just as well, if not better, than everybody else in having viral suppression and, in a sense, having a good response to antiretroviral therapy. Next, please. So I think the key points of the demographic shift, or at least two of them, are that we as medical providers need to be alert to testing older individuals. HIV doesn't stop at any particular age, it continues on. And if you're not diagnosed at a younger age, then the processes aren't interrupted. And of course, older individuals also acquire new infection. Secondly, when we do encounter individuals over the age of 55, we need to reassure them that treatment is good, it's effective, and that there is nothing about their age that will prevent them from having a good response. Next, please. Now, a couple of slides on the consequences of aging with HIV. One of the obvious consequences is that individuals certainly have increased numbers of comorbidities. These are data from a Ryan White clinic in the Southeast, and it shows what is intuitively obvious to all of us, that as individuals age, we acquire biological hits, so to speak, so that by the time you're over 50 or over 60, the majority of individuals have several medical comorbidities. And indeed, in my own practice, I often spend more time managing comorbidities than I do managing the HIV. Next, please. Now, one of the not so obvious consequences of aging with HIV is that there appears to be a potentiation of chronic disease onset by the HIV virus. And these are data from a national database of insurance enrollees who were aged 50 or over and were followed for at least 1 year. And the goal of the study was to evaluate the magnitude of association of HIV infection on those 7 conditions that we often deal with, such as diabetes, high blood pressure, stroke, and others. Demographics, behavioral risk factors, and chronic comorbidities were controlled for, and the data are presented as a risk ratio between HIV positive and HIV negative individuals for developing one of these 7 comorbidities. Next, please. So as you can see across that top line, these are data at a 2-year interval, and I'm not showing data at 5 and 10 years, although they look almost identical, is that it crossed each of these 7 conditions. Individuals with HIV were at a significantly higher risk for developing these problems after they were enrolled and after they were diagnosed. Next, please. And when the investigators teased out individuals who were diagnosed before the age of 50 and compared them to those who were diagnosed after the age of 50, it's very clear that they're on the bottom line. If you were diagnosed with HIV over the age of 50, your risk ratio for having things such as diabetes, hypertension, or developing cancers or lung disease, and in particular cognitive impairment, is actually quite high and is higher than if you were diagnosed at a younger age. Next, please. And so the point of this is to say that HIV status is significantly associated with higher rates for all of these chronic diseases, and that those who are diagnosed after age 50 are at a higher risk of chronic disease onset compared with those who are diagnosed before, or even those who are HIV negative. Next, please. And one of the key things looking forward that we as practitioners need to be aware of is the development of cognitive impairment. This is a meta-analysis of about a dozen studies looking at cognitive impairment in folks with HIV who are over the age of 50. And what you can see is that there was about a 2.5-fold increased risk for the development of cognitive impairment if you also had HIV infection and were aging. And so this is something that as we age and as our patients age, we need to be aware of and need to think of ways and be very intrepid in addressing this. Next slide, please. So to conclude, there are increasing numbers of older HIV positive patients, and this is due to better antiretroviral therapy, portending a longer lifespan, but also because patients get infected at an older age as well. Older individuals clearly have more medical comorbidities, and those diagnosed with HIV over the age of 55 are going to have more advanced HIV disease, but they still respond very well to antiretroviral therapy. And then remember that HIV infection can be an aging accelerant and accelerate development of many common age-associated comorbidities, including cognitive impairment. Well, thank you very much for your kind attention. I'm very much looking forward to Dr. Duncombe's talk.
Dr. Duncombe, if you want to
Yeah,
go ahead and go forward.
yeah. Thank you very much. Thank you for the talk. That was terrific. So I titled this talk "The Intersection of Aging, HIV, and the COVID Pandemic," and I'm also going to talk a little bit about COVID-19 vaccinations in people living with HIV and also in the older population. Next slide, please. So with the pandemic now in its second year, we've learned a great deal about how COVID-19 or the coronavirus impacts both people living with HIV and also older people. And there have been multiple case studies of COVID-19 and HIV from diverse geographies, both in the US and in other countries. And there are very clear data, I think, on COVID-19 and aging, the impact of aging on COVID-19. And what I think are variable messages on the intersection of COVID-19 and HIV, which I'll touch on in a moment. Next slide. So we know that people, certain people are prone to having worse outcomes in terms of COVID-19, in terms of hospitalization, intubation, and even in terms of death. And one of the significant risk factors that comes up in almost all of the studies is age. You can see here just a selection of published studies, and the predictors of worse outcomes are aged over 65, aged over 55, and you can't really see the bottom one, the impact of age on viral shedding, and people who are older shed the coronavirus for longer periods of time than people who are younger. Next slide. So in terms of the impact of HIV on COVID-19 outcomes, the early clinical case studies when they first started to come out were very small numbers. You can see in the green box, one of the earliest studies from Barcelona, because Spain was one of the countries hardest hit, along with Italy in the early days. Just 5 people who had COVID and co-infected with HIV. Barcelona, you can see next to that, 53 people. And by now, these clinical case studies have gone. There's more than 100 of these have been published. Next slide, please. But also what we've learned is data now from large cohort studies, and these are 2 that I'll just show. If you look at the top left-hand corner, these are risk of COVID-19 death among people living with HIV from Ministry of Health in Western Cape in South Africa, and among 13,000 cases of people with HIV and COVID, there were 435 deaths, and the risk of death in that cohort was double that compared to people who were not living with HIV. NHS England mortality data, this database was called Open Safely. It was meant to monitor the opening of England way back in the early days when we thought that was going to happen. But in fact, as the UK tried to open, it very quickly closed back down again. And this database represents 40% of the English population, 27,000, a little more than 27,000 of the 17 million people in this database were living with HIV. And the data presented here show there was nearly a 3-fold increase of dying from COVID-19, adjusted for age and for gender, if you are living with HIV, and the hazard ratio is there 2.9. Next slide, please. This data from New York City, amongst more than 100,000 people living with HIV in New York City, nearly 3,000 diagnosed with COVID in the times when New York City was really badly hit by the epidemic, by the pandemic. You can see that hospital admission, 2.61-fold increase or risk of hospitalization if you are living with HIV, and a 2.5 increase risk of mortality if you are living with HIV. Next slide. Then we see data like these. These data come from Marina Wallace, who analysed 31 published studies covering 6,900 people living with HIV. And in her meta-analysis, she concluded, taken together, that the biggest risk factor was in fact comorbidities and aging, and not specific HIV variables. So it's a complex thing trying to see how much of this is driven by HIV itself and how much is driven by other risk factors, including the ones we know about, HIV and age. Next slide, please. This was published at the International AIDS Conference in July of this year, the WHO Global Clinical Platform. These are data on people with HIV and COVID-19 from 37 countries. This database includes 15,500 people. And WHO concluded that severe COVID presentation at hospital admission and in hospital mortality was in fact higher in those people with HIV. What I think is interesting about this report is, in fact, 85% of the 15,000 people in this particular cohort were in South Africa. So that to me is an interesting fact, that if you disaggregate the mortality and severe presentation by country, and you just look at the United States, and in the contribution of the United States to this database is less than 1%. There was no difference in hospital severe admission and death in people living with HIV compared to no HIV. So that's what I said earlier. I still think that there is an increased risk, but if you look at the data and you follow the data, we are seeing data that is kind of different depending on the way it's analyzed and the way it's presented in terms of, does HIV have an impact on COVID-19 outcomes? Next slide, please. So very quickly, just coronavirus vaccination and HIV. Next slide, please. So people living with HIV have been enrolled in the pivotal coronavirus vaccine studies. You can see here the Pfizer study, 196 people, Moderna study, 179, the AstraZeneca vaccine, 160. And what we learned from these numbers are very small compared to the enrollment in these studies, which is around 40,000 in each of the studies, that there is no signal that there is any safety issues in people living with HIV. It's not possible to look at efficacy data because the numbers are too small. Next slide, please. Next. Oh, yep. So earlier this year, there were reported data that show that there are no differences in immune responses with the AstraZeneca Oxford vaccine in people living with HIV compared to those without HIV. And just recently, there were data from Johns Hopkins University showing that the Pfizer and Moderna COVID-19 vaccines produce strong antibody responses in people living with HIV after 2 doses. Next slide, please. So the first study, just 5 people received Pfizer, 9 people received Moderna. The median age is interesting. These were older people, which is interesting. The median age of this small population was 62. The antibody responses were the same whether the person was living with HIV or not. In the second study, 12 people with HIV, 17 negative, got the Pfizer vaccine, median age of 52, again, an older age group, and the antibody responses were similar. Next slide, please. So in summary, the COVID-19 vaccines are safe and effective in small studies in people living with HIV, including those in an older age group. And that's my last slide, so I'll stop there. Thanks very much.
Okay, thank you. I would like to ask all the participants and the panelists, if you have questions of each other, we'd like to have a discussion. I think the importance. Oh, I'm sorry. We have another presentation. Ligia, I'm sorry. I thought there were only 2. So, Dr. Peralta, go ahead.
Thanks, Dr. Drevets and Duncombe. Thank you so much for paving the way for me to share through my lens on working with the community, the Black and Brown community, the impact of the pandemic on the HIV screening and treatment and care. And I have selected that because this is my program now, and we have created an innovation program to be able to bring access to care for those who were left behind by the pandemic. So I'll share a case, a program, and brief recommendation, more a call to action. So I'll detail the disparities, the barriers for some of the special population, in this case, immigrant, and the need for implementation research. So about 2 weeks ago, I conducted a large COVID-19 vaccination event which are done basically at churches. And there I met a lovely woman who refused vaccination due to health concerns. Few days later, she asked me to see her at the foundation, and she was a really chatty, lovely 64-year-old woman who migrated to the United States about 3 years earlier. She reported feeling tired, had arthralgias, lack of sleep, forgetfulness, and somewhat with mood changes. She had basically in November 2020, she said that she experienced fever, cough, lack of taste and smell, and was very sick, but could not afford to go to the hospital due to lack of insurance, and took remedies from her home country. She visited an urgent care facility and a community clinic later on in 2021, had negative COVID test, and was referred to a mental health provider after losing her job, being victim of interpersonal violence, and experiencing financial hardship. So her constellations of symptoms, although she was never tested for HIV at an early stage, for COVID-19, cover many of the long COVID symptoms, but she also had a new partner with a good sexual history. Upon arrival to the US, she entered into this relationship and had some dysuria and also some incontinence at this time. I tested her for STIs, HIV, hepatitis C, and the 4th generation HIV test confirmed that she was living with HIV. For some who are not engaged into this deep community work, and we serve also tertiary care clinics, this is not as unusual because basically we find them in the community. So I'm going to dissect a little bit this case about what happened, where did we miss the opportunities here? So the COVID-19, next please, the COVID-19 pandemic has been a threat to public health gains, and the USAID's report in 2021 basically describes the disruption of services at the international level, as well as what we see here in special populations like the migrants. And we have been focusing on the pandemic, COVID-19 101. So we missed the opportunity to test her for HIV and to do prevention. We missed the opportunity for rapid ART implementation. We know that the science is there, that if we implement rapid ART, we reduce morbidity, mortality, and the transmission, which she was very interested in. But also, we missed the opportunity for linkage to comprehensive primary care. This woman had not received even primary care vaccinations for pneumonia, flu, and nobody had talked to her about COVID-19 vaccinations. So this case, next please, illustrates the disparities in special population of immigrants. The Pew Research Center has, indicated that, immigrants have trouble paying for medical care, and that overall 6 in 10 Latinos say that they have experienced at least one of several financial challenges. And the top of that is the trouble paying for medical care. But also nearly 6 in 10 Latino immigrants without a green card say that they or someone in their household has lost a job or taking a pay cut. So we are talking about the true social determinants of health. Next one. The other part is that federal policies and immigration status are quite complex for our population, especially of immigrants. And this case illustrates the barriers that many immigrants already face, long-standing federal barriers to accessing federally funded benefit programs as set in places like for example, California or Massachusetts, but otherwise under the Personal Responsibility and Work Opportunity Act of 1996, unauthorized immigrants and most authorized immigrants with less than 5 years of US residency are excluded from receiving federally funded benefits. The same thing happened with the Affordable Care Act. So we are talking about barriers to federal funded benefits, lower utilization of care, and lack of affordable care. The next one, please. So clinically, this is what we see, and thanks God, we have now the post-COVID-19 conditions guidelines from the CDC, but we have in general lack of clinical research in terms of post-COVID-19 and the presence of HIV, especially when my colleagues already spoke about the neurological and neuropsychiatric symptoms that could be deeply confusing for many people, especially where our immigrants are receiving care for the first time. So in general, Latinos are overrepresented in COVID and of course the post-COVID-19, but underrepresented in the research. And most of them try to escape hospitalization due to fear. And unfortunately, they will not be able to be linked, even in the presence of post-COVID-19 conditions, to centers, and especially tertiary care centers, big hospitals, where they can receive services and be linked to care with appropriate care. So in this case, the next one, we have there pretty much all the post-COVID conditions listed on one side, but the ones in the blue, what our patient had. And patient advocacy groups, even at the level of Congress and testimony in Congress, have raised concerns that some post-COVID conditions have been either misdiagnosed or misattributed to psychiatric causes, particularly among persons who belong to marginalized or the vulnerable groups. This is the case of our woman, our lovely woman. Not only we missed her HIV, we also miss her long COVID. Next one. And finally, worsening of the mental health problems for PL-HIV. The mental health system has been overwhelmed, especially at the community sites. And when COVID has been so prevalent, it has been very, very challenging to serve our people living with HIV with increased social isolation and psychological and financial stress with the adequate mental health services. For many of our patients, as you know, they are not that savvy in terms of using smart technology or computer, and telemedicine has been really a very challenging situation when we talked about this type of community. Next one. So they're promising solutions, and I just, we heard about the ending the HIV epidemic in the US, and a very, very nice presentation about the 12 million CDC award for comprehensive ending of the HIV epidemic programs at the level of the health departments. This money comes from the HHS Minority HIV/AIDS funds. And I was very, very happy to see that not only the jurisdictions are going to be using the people who have been affected by this pandemic, but there's also innovation into these programs, into the programs that are being developed. Unfortunately, we are like 1.5 to almost 2 years delayed in terms of implementation. But this is the part where we are going to go back to increasing the testing, and perhaps self-testing is one of the areas there, but also taking the test to the community where it belongs in a much easier way than we used to do in the past. expanding the linkages to care, which this lovely woman didn't have the opportunity, expand PrEP, linkages, addressing the opioid pandemic in a more innovative way, and addressing this endemic HIV, STI, viral hepatitis, and of course, this syringe services programs where that's allowed. So next, I would like to pose the call to action to identify key HIV prevention innovations and adaptations that could be supported and also scale up to regain the US HIV prevention momentum. Get involved in the ending to HIV pandemic in the US at your local level. We need to continue learning from this pandemic to update what we do in terms of implementation research at the local level in our communities, but also facilitating access to care and identifying key HIV prevention innovations and adaptations that could definitely be scaled up, especially for our aging individuals who are staying at home. So next. My last slide is to just give you the flavor about how we propose the innovation. This is an example as a result of the pandemic. We moved our prevention efforts for HIV and STIs to the community and linked that to COVID-19 testing and vaccination at the same time. So it's really a comprehensive screening to be able to deliver the service and link these individuals to care. This is the result of why we found this lovely woman who we were able to help, although she didn't get the proper care at the time, we were able to find her in the community. So the pandemic has allowed us to address the health disparities in the heart of the community. And this is something that we have learned to do in a much easier way than we did with HIV screening in the past. We learned from HIV, but we are allowed to innovate with COVID-19 pandemic. So now it's time to learn from those lessons from the pandemic and apply them to innovate services for HIV in a much, much easier way for our population. So with that, thank you.
Okay, thank you. I believe our next speakers are not using PowerPoints, and we're going to have Ms. TeKampe talk first, and then Mr. Zaldivar.
Yes, thank you very much. Yes, you just get to stare at my face as I talk. My name is Erica TeKampe. I'm from Phoenix, Arizona. I run a program called HIV Care Directions. We provide medical case management and other supportive services to individuals living with HIV so that they can live a long and healthy life. We happen to also be a program of the Area Agency on Aging. And even though we serve individuals of all ages, as HIV is entering its 40th year, and our program's entering its 30th year, the intersection of our aging services at our larger agency and our HIV services in my program is certainly increasing over time. So I want to just share some information about the psychosocial issues that our clients are facing as they're aging. Dr. Drevets already did this amazing review of the comorbidities and the issues that affect them medically. And I'd also just add to that the issue of polypharmacy. Our clients, when they first started with HIV many years ago, had lots of pills to take, and luckily that decreased over time. A lot of them can just take one pill once a day, but now as they're aging, they're adding a lot more pills back into their daily routine. And so that is really challenging for people. Also, a lot of our patients are just worn out. They have been dealing with this chronic condition for many years. They're now having increased comorbidities. So physically, their bodies are wearing out maybe a little faster, like Dr. Drevets alluded to. But I think also we can't forget how that is emotionally draining. It's mentally draining. And so they're kind of worn out there. It's hard to be adherent day after day to medical routines, which are only becoming more complex as they age. A lot of our clients honestly never thought they would live this long when they were newly diagnosed many years ago. And when Dr. Drevets showed on the chart that great decrease that happened, I was working in our program when that started to happen, and one of our clients called and left a message on our answering machine. That's how long ago it was. And he said something I'll always remember, which was, I was ready to die and learning how to prepare to die from HIV. And now I have to learn how to live because these new medications had come out. And, that's really something to think about. A lot of our clients, they spent their savings, they sold their life insurance policies. They went on disability because at the time, their HIV infection, made them eligible. And now here, all these years later, maybe they've been on disability all this time. And even if they're wanting to get back into the workforce, the challenge of that, not having a work history, is very difficult. They've watched, lots of friends die. They've lost partner, spouse, maybe a couple partners or spouses. So they might be feeling very alone. They may not have the family support that people have. A lot of these people diagnosed at a time when there was not as much understanding about HIV. And if they're also LGBTQ, there might not have been understanding about that. And so they don't maybe have all the family supports that other people do. And we know that older adults deal with isolation, and now add on to that HIV, and that's still, there's a lot of stigma associated with HIV. And again, an older population who grew up in a time that stigma might be even stronger to them. And especially, again, if they're part of the LGBTQ population, being out maybe wasn't as acceptable, and they might have grown up facing a lot of discrimination that, hopefully today our individuals don't face as much, though definitely it still does exist. And then for us in Arizona and for many parts of the country, we have a lot of individuals with an immigration status which doesn't allow them to get a lot of services from our government. Thankfully, through the Ryan White Care Act, individuals can be seen even if their immigration status is not making them a citizen. So we're really fortunate that we can provide that service for people, but there's still many things we can't, lots of times housing, income. And so again, as people age and maybe now aren't able to work in the same way they could before, they're now finding themselves in a situation where they can't support themselves in our country. And yet, returning to where they may have originally been from may not be an option. And yet they don't have supports here. And especially if they get really ill and need, placement in some type of medical facility, that just can be really challenging. So a lot of issues that we're facing, psychosocially as case managers and trying to help our clients manage. I liked how Dr. Peralta said a call to action, and I actually do have a few ideas of call to action for medical providers and what they can do in addressing HIV in older adults. And one of the things is really, as a provider, is looking at what, unintentional biases we may have when thinking about HIV and who gets HIV. As Dr. Drevets said, anyone can. And so we need to remember that, how is the paperwork phrased, for new patients coming into a practice? What kinds of questions are we asking? Are we asking everyone about HIV and their potential exposure or current infection? Because they may or may not feel comfortable sharing that themselves. And so if we make it standard that it's things we talk about with every patient, I think it makes it less difficult for the provider because, of course, as providers, maybe we have some of our own biases. Maybe we're uncomfortable to ask those sexual health questions. Maybe we're worried our patient's going to think we think something about them. And so if we just normalize it, we go over these questions with everyone, just like we would do about alcohol or drugs, smoking, make sexual health just part of all of that. We can really show that we're comfortable to get those honest answers back from our patients. Also, as already was put forth, routine testing and screening. Today we're talking about individuals who've been living with HIV and are aging with it, but we do want to make sure we're not missing the people who are acquiring HIV later in life. Sexuality doesn't end at a certain age, and so we want to make sure that we are still remembering to test. And again, making it just part of routine healthcare. The CDC recommends that everyone, and they put a limit up to age, or a suggestion up to age 65. I would say there's no upper limit, but everyone should get tested at least once in their lifetime. And honestly, I think it would be great that it was just a part of routine medical care. You go in once a year and you get your well check, and blood draws. Let's make HIV a part of that as well. And that way we do find people earlier in infection, where hopefully then we have better chance for interventions and better outcomes for them. And then my last kind of call to action would be that, as a medical provider, if you do find yourself, serving individuals with HIV, make sure you get educated, provide that great knowledge, and share that with, HIV providers in the community. I know in Phoenix, we have a lot of great providers, but we serve a really large geographic area, and that we can have providers throughout our valley to offer more options for patients so they don't have to travel as far to just central Phoenix. We're always glad to find new providers, and it's just so welcoming for our patients when they have more options available to them. So thank you for your time this afternoon, and again, test and get yourself educated, which just by being here today, you're doing. So thank you.
Awesome.
Thanks, Erica. Richard, you're on next.
Yes, thank you so much,
From
Dr.
Los Angeles.
Yes, absolutely. Go Dodgers. It's a pleasure to be here, and thank you, Dr. Rios, for the invitation. What a great panel. It's a great day for an opportunity to set aside a safe space to have this conversation. First of all, I want to just say that in my explanation, first of all, I'm the executive director of the Wall Las Memorias. It was founded 28 years ago. I'm the founder. Behind me, as you can see on the screen, it's a photo of our AIDS monument that we're rededicating on World AIDS Day. It's the only publicly funded monument in the country to those who passed away from AIDS. We provide prevention services in HIV, substance abuse, and mental health preventions to the LGBTQ transitional age youth. But I just wanted to touch upon some issues that we face in our community for those who are 55 and over dealing with either HIV or full-blown AIDS. First of all, I just want to say that geography dictates the environment, how to address HIV today in our communities. How we address HIV in Los Angeles, San Francisco, or Chicago, or New York is going to be a lot different than we're going to be addressing in middle America, rural America, or the South. Real big differences. Where Los Angeles has been a hub, or New York has been a hub for gay men or bisexual men participating in general community life. It's a lot different in your smaller towns or your rural areas. So we're going to have different experiences. I want to just say that from our community, there has been tremendous anxiety during the COVID pandemic. Not knowing the HIV populations, particularly those who are 55 and over, how they would be able to handle a second infection or a new infection from COVID while they were positive. On another hand, though, there's tremendous anger from a lot of our folks in that population because there's no vaccine for HIV. And they have been waiting and waiting. And here now with COVID, it took 1 year to identify and develop a vaccine. So there's a lot of anger, isolation, mistrust, and they also feel slanted because COVID has taken the attention away from HIV. Here we are in the 40 years of AIDS and HIV, and the focus has been on the COVID pandemic. So again, our community who has been living in the closet or grew up in the closet, only to come out and have to battle for prevention and care services, is now back pushed under the rug. I think that our population that experiences also a disconnect from the LGBT community. When you talk about generations, you know, it's hard for 55-year and older to identify with the 20 and 30 years old who feel so confident about being who they are and being in different spaces and being on television. The older population cannot relate to that. There's still many of them are living in the closet, and so they don't feel safe. You know, older people, 55 and years older, they grew up at a different time. The socialization skills and models were different. Back then, there were bathhouses, right? That's where Bette Midler got her start in New York, or Barry Manilow. There were gay clubs. Today, it's different, right? In large urban areas, everyone is integrated into one community when you look at outlets. So there's been a closure of gay bars throughout the country, especially due to the COVID-19 pandemic. A lot of businesses could not sustain the financial hardships. So this community, you know, they've lost their places of socialization, and we have to take that into consideration. I also want to talk about the Latino community in regards to HIV, where a lot of our community has experienced racism within the LGBT community. And this has been ongoing, and it's very prevalent even in Los Angeles, where there's a major problem even with the Los Angeles County HIV Commission, where the voice of the Latinos, as we're growing in numbers, you know, it's hard for the other communities to give up power or to cede power or influence. When we talk about immigrant population, you know, when mainstream HIV AIDS communities and programs, we look at Latinos as being very generalized, right? If I'm Mexican American, you know, am I being lumped in with a Central American or with an immigrant from Mexico? And they're really different subcultures that we have to look at and be conscientious in providing services, because we're a lot different. Although we may all be Latino, we all may be brown, right? There's a big difference. And I think, you know, we still, when we talk about folks in their later years being diagnosed with HIV, they're still dealing with internal and environmental homophobia. Many of the men and clients that we have seen over the years have a different perspective than the younger generation. There's even more of a hesitancy to going to the doctor and getting on PrEP, right? And the reason for that is many times the doctors that they've had for so many years, and many of them have been family doctors, don't prescribe to PrEP. They will frown upon it, causing a greater stigma, and the men come away saying, okay, my doctor is saying he can't prescribe PrEP to me. He doesn't have enough information about biomedical treatment, prevention treatment. So there are definitely some big problems when we're looking at our community. And also I want to just share that the tremendous amount of loneliness and isolation. I remember having a conversation with the leadership at the CDC. Their biggest problem in the area of HIV prevention and treatment organizations throughout the country is that there's a generation gap. The older generation, primarily 55 and above, were getting burned out by providing these services, by being leaders. And so the only ones they would be able to turn to were the 30 and 40-year-olds who didn't have that kind of experience in leading nonprofit organizations. And so we're seeing a tremendous amount of burnout from our community. And then the last few items I just want to mention, what we also have seen during the pandemic, as I mentioned, that a lot of the older gay men, their form of socialization has been bathhouses and sex clubs and gay bars. So during the pandemic, they were closed and they don't necessarily go out to dating apps. So they take chances and risks. And so we have seen an increase of crystal meth use in Los Angeles and in other parts, large cities in the West Coast that we're also addressing through a community campaign. But we've seen an increase of drug use and alcohol use among that population. And then lastly, from one of our several clients and one of our staff members is that there's a medical fatigue. Our folks are getting tired of the daily doses of medication and going to the doctors on a constant basis. They know they have to do that in order to be healthy, but they're getting tired of it. And then lastly, the last few comments I just want to share, because I know we're running a little late and behind. When we're talking to our clients, especially Latinos, we have to also be very conscientious of culture. And part of our culture incorporates a sense of spirituality. A lot of the major religious institutions that Latinos prescribe to have kind of frowned upon sexuality and gay and bisexual, lesbians and transgenders. We know that, we understand that. But our people still are spiritual. And so they constantly look for a spiritual opportunity, a spiritual outlet to solidify who they are as an individual. So when we're working with our population and providing services, please keep in mind that we may not go to church every Sunday, but you can bet that in our house somewhere there's a picture or a frame of the Virgen de Guadalupe. If it's not in our house, it's in our mother's house or our tia's house. So with that, I just want to say it was a great opportunity to participate, and I thank you for allowing me to join you.
Thanks, Richard. So now we're going to start a discussion. Again, if anyone has questions, please put it in the Q&A slot. We have quite a few set questions. There is one question that has come up among the participants. And Richard, let me just ask you, since you were just mentioning a lot of the different groups that you serve and a lot of the biases that you see in the community. We have a question about the Latino community that is heterosexual and male. And what would you say to that in terms of hope and services? Again, every region is different, but would you say in terms of asking for help?
So, yeah, I thank you, Doc. Alberto, I think it's important when I saw your questions a few times about it's not a gay disease. I happen to be heterosexual. And I think the misfortunate part of this is the fact that, we kind of generalize, because when we look at men, Latino men, the majority of cases have been among gay or bisexual men or men who have sex with men. So, I think it's not a slant to heterosexual men, but I think that, how do we roll out programs and messages? But I think we do it on a cultural basis. I see your name is Perez, you're Latino, right? And so as an individual, how can you help and work with organizations or even with your medical offices to identify other men or women just like you, to get them into care, get them into prevention, but more so get them into community action? Because we don't have all the resources that we should have in our community, right? If we had all the resources, then there would be organizations specializing in heterosexual Latino males. And so HIV is not just a health issue, it's a social justice issue. So I hope I answered that.
Yeah, I'm gonna go around the table here. Dr. Duncombe, can you answer the question? There's another question in the chat about the question asked about Zoom fatigue and COVID in general with a lot of people, but from a medical standpoint, how are you dealing with that? Oh, you're muted.
It's off now. It's off now. Sorry about that. Yeah, I think all of us are facing Zoom fatigue. You know, it's our lives have been changed, and just when we thought that things were going to get better, they just did not get better, and we are still in a pickle. So, what can you do? I mean, you know, you make the best of it. You try to go out when you can. You try to socialize as best you can. I mean, mostly, you know, a lot of us now can go out with masks, and you know, the controversies over masks just are just. They are what they are, but you know, we still have to be careful, but we still have to be mindful that isolation, loneliness is a real issue with this pandemic, and even though we thought vaccines were going to take it away, they just so far have not done so. So we are really stuck, and we have to cope. Yeah, it's difficult for some people who don't have the ability to interact and be social. Their loneliness is a real issue. Yeah.
Yeah, let me ask a question. The other question that just came up was for the Latino community. Let me ask Erica, since you deal with the aging agencies, thought maybe you might know, are other aging agencies delivering messaging to the Latino community with HIV? There's a question here about, you know, what's the link to Latino communities in, and you might all want to answer, because you're all from different types of service agencies or medical schools. And how are you linking to the Latino community with HIV?
Yeah, I mean, definitely HIV and aging is kind of the hot topic of late amongst HIV communities. And so everyone is trying to work more that way. And, you know, with the Latino community of any age, that's always been a very important community in where, you know, in Phoenix, where I live. It's always a challenge to reach communities who traditionally are not as, don't access services in the way that our system is kind of set up to do. When Dr. Peralta was mentioning that ending the epidemic money, Maricopa County, where Phoenix is one of the jurisdictions that's getting some increased funding and trying to do some of those innovative programming. And one of the things we're really working on is the concept of using individuals living with HIV to go out and give these messages. We're starting a community health worker program. You know, there's a lot of promotoras programs, you know, regarding other health issues. So we're kind of trying to use that with HIV, because I think a lot of times, you know, these populations, you know, and kind of any population, when you hear it from someone you relate to, who, you know, looks like you, acts like you, sounds like you, whatever that might be, that's comforting. And sometimes you just give that more credence. And so we're trying to build some programs like that, really reaching out to the community in a way that's maybe more comfortable to them and kind of help bring them in to our services.
Right. And Dr. Drevets, I think it was Dr. Peralta that mentioned the call to action for bias, medical bias. I shouldn't say medical, but you know, we have so much bias in the medical profession, all professionals, and it's just because there's so many different people that we take care of, and not doctors don't necessarily come from Hispanic communities. We have, you know, only 5% of doctors are Hispanic. So how do you think medical schools like yours and others should start dealing with the issue of bias with HIV/AIDS patients, and how can we improve the awareness of the next generation of, as Richard was saying, we really need to start thinking about how to educate the younger population about HIV, who haven't gone through all the struggles and you know, that the I'm not going to say older, but I'm going to say wiser HIV advocates have been dealing with. And I think medical school education is very important, and is changing to have competencies in communication and respect for social determinants of health and where patients live, where they come from. What would you say is important for our discussion today?
I think
ask
Please.
you,
No,
Dr.
go ahead
Drevets,
first.
and then I'll ask Dr.
Ladies first.
Oh, okay.
You
ahead.
first, Dr. Drevets.
Okay, if you insist. So I think that's a great question. And in terms of things that we're doing locally, we do have an active program on campus to look at bias and to try to deal with that in our own practices and things. In terms of medical student education, in our group, we work with the medical students. We provide the HIV lectures as well as lectures and in other series, like one of my colleagues who's our Ryan White program PI, principal investigator, gave a departmental grand rounds on taking a sexual history, just because it's not something that's so common. You know, and in terms of a bias that we find that happens with the aged, and by aged, I'm using that kind of loosely. You know, often we just don't think about testing folks over a particular age for HIV. You know, one of the patients in my clinic had a midlife crisis in his late 50s, and instead of getting a Harley, decided to turn to IV methamphetamine, and ultimately, a few years later, became HIV infected, had several years of poor health, and was never tested until he developed cryptococcal meningitis. And I think it was that sort of a thing. People just didn't think about testing a gentleman over the age of 60 who kept coming in with recurrent sinusitis and then developed thrush with antibiotics. You know, HIV was just not on the radar screen.
Yeah.
So there are a lot of things to do, and it's you know, it's also a moving target, and we have to be intrepid in how we address it.
Dr. Peralta, you wanted to add?
Yeah, just to add that one very, very interesting aspect of this is being able to, for example, during COVID, in what we did was we recruited medical students like we have done in the past for HIV training, but to deliver the services in the community. And that took me back to my own training. When I trained in Connecticut, I had to do house calls, and that was part of the training. I think that makes you comfortable with the community, makes you comfortable opening up all your senses to learning and also to seeing different cultures. But the other part of that is the interdisciplinary nature of the training, I think, is key. This is what we have today in this panel, and it makes it so rich because every single person has brought something unique. And this is part of what medical students and other disciplines can bring to each other.
Yeah. And Dr. Peralta, you also brought up the importance of the 5-year waiting ban, you know, for
Yes.
especially the Latinos that are undocumented, or those that are are DACA or others. But we have a bill that was actually called Lift the Bar. And I'd like to mention it because it's so important. So the National Hispanic Medical Association, we do advocacy here in Washington, D.C. And this bill was introduced by Congresswoman Jaya Paul and Congressman Cardenas. Tony Cardenas is from Los Angeles. This is just to be able to lift that bar, that 5-year bar, that would eliminate the 5-year waiting period for access to Medicaid, CHIP, SNAP, which is the food stamps, and temporary assistance for needy families, and the SSI income. And as you know, that this bar was put in place as part of welfare reform in the Clinton administration, at the very end of the Clinton administration. So we're looking forward to seeing that actually pass.
That's what I call innovation, Dr. Rios. It's excellent.
Yeah. Well, there's a lot of organizations here that are all for that bill. So I want to say that it is really important. And so let me turn the question to a few questions about Latino population. So we have a real problem with access to healthcare. How do you see, with the aged or over 50 population, how do you see having educational programs, let's say through the primary care doctors, or honestly, I guess with the primary care doctors that are taking care of the older patients with diabetes? with heart disease, with cancer. You know, how do you see them learning more about HIV and testing? Dr. Duncombe, do you want to answer that one? And it may not be just Hispanic, but the issue of, you know, how do we get to the primary care doctors? Because our Hispanic population is very, very much, you know, sick. If they can get to the doctor, then they can get educated. If not, it's going to be the community services and the community agencies that need to reach out to them. But Dr. Duncombe, what do you think?
I think it's really important that, you know, HIV is integrated into primary care, and that's one of the things that we try to do everywhere. A lot of my work is in other countries, particularly in Africa, and integration of HIV into primary care it's just not there. In my country, Australia, it is. In other countries, it is. So you can do it, and it does work. And you know, primary care physicians should be trained and confident in being able to diagnose and treat HIV. So I think the secret is, for me, is to actively promote the integration of HIV into primary care.
Yeah. And let me ask Dr. Drevets, what about mental health care and the training about, you know, we heard about the comorbidities with HIV, AIDS, and the aged population. It looks like the dementia and just having mental health testing of older patients that have HIV is very important. Is that something that the medical
Yeah, as I'm sure you know, mental health and access to mental health is a somewhat of a national tragedy.
Yeah.
And I just think that's going to take huge amounts of effort to put that in and to do it well. Let me piggyback onto something that Dr. Duncombe just said. You know, I work with our local AETC, AIDS Education and Training Center, and we actively reach out to primary care providers and other healthcare practitioners and provide HIV and hepatitis C education at no cost. And I've been involved in that effort now for probably 10 years or more. And so that's one way that many people can help and can learn about how to integrate HIV care into their practice. And it can be done. You know, it's like I had to learn how to integrate diabetes care into my infectious diseases practice, which I'm still trying to sort out some of the newer drugs, you know. So I can appreciate how that goes. But mental health is a real challenge. And I think that's another thing that those of us who do HIV care have to in a sense, learn another trick. But it's difficult. And I'm fortunate that we have a great group of counselors that I work with in our Ryan White program. So they are very helpful.
So could you maybe, Richard, I don't know if you're aware of the difference. I think just for the audience, it would be important to know these federal programs for HIV/AIDS. The Ryan White program is one from HRSA, and the other one is the HETC that you mentioned. And Richard, as a community-based organization, do you work with both? Do you have a sense of the difference in treatment services?
We actually work primarily in prevention services. And so we work with CDC and SAMHSA. We are doing some work with HRSA on a COVID response. But primarily prevention's run through CDC.
Eric?
Elena, I can address that if you like. So Ryan White originally was called the CARE Act. Now I think it's the HIV Treatment and Modernization Act, started in 1990, and is about care and services. So when people don't have other payer sources. So it funds everything from medical care, prescriptions, to, you know, substance use, mental health, case management, nutrition, transportation, all with the purpose of, you know, what can we do to help people get medical care, get on medications, lower their viral load, you know, and live a healthy life. So that's where a bulk of services money is. There's also money from HUD, specifically for housing. It's called HOPWA, Housing Opportunities for Persons with AIDS. So there's that big funding stream that's about housing, and then, like Richard said, you know, money from CDC for prevention. Within all those, groups. They're trying to coordinate better and not be so siloed and really, blend and work together. So I think that's kind of the main three funding streams that are HIV specific.
And Dr. Drevets, you mentioned the AETCs, the HIV training centers for I guess training for primary care.
Right. It's a national program, and it's the education arm through the Ryan White through HRSA, and it's broken down into, I think, 7 different regions. And here in Oklahoma, we're part of the South Central AETC, which includes 6 states in our area. And we are working with, our job, of course, is to work with folks here in Oklahoma, including the tribes. And we've gotten much more aggressive into things such as practice transformation and interprofessional education to help get the message out and train more people and try to train trainers. We have preceptorship programs before COVID where we would have people come into our clinic and do things. So it's a good outfit. They have a lot of resources and really do a lot of good work.
Yeah, we've been involved here in Washington, D.C. with the Howard University program in the past. But let me thank everybody. We're at the end of the time here. I want to say that we really covered a lot of ground, and it was great to hear so many different perspectives, medical education, as well as community-based services and leaders from the innovation world, looking at the link between HIV and COVID, and also the importance of continuing to pass the baton on to the younger generation about the importance of treatment of HIV. And the end HIV epidemic is something that we're all very interested in getting more people to get involved in. I think the biggest call to action is to join the end HIV epidemic service with all the different government programs, as well as medical education and our community work. This is just a contact information, NHMA, our website, and we invite you to come to our conference in March. We also have a real need for HIV speakers. If any of you'd like to speak at our national conference, we'd be happy to have you. We're very interested in making sure that we educate primary care doctors through our conference. We get a lot of Hispanic doctors from around the country. And I have to say that we are starting councils by specialty, Council of Internal Medicine, Family Medicine, to try to find a connection between medical students, residents, and doctors, and try to increase the mentoring and role model in between. So if you have any, and anybody in the audience with information interested, for NHMA and Latino patients especially, we're very excited about continuing the HIV work with the CDC. We just got funded for another 5-year cooperative agreement. We'd be happy to work with all of you. We're very interested in getting more speakers out to the community and dissemination of information about HIV through our networks. So thank you very much. And I guess, well, one last thing is we do have the NHMA Vaccination for All campaign that was on there. And our next briefing on COVID, we do a lot with COVID, will be about women, pregnant women. And Claudia Zamora from our board of directors will be the moderator. And we have speakers coming from Virginia and Maryland, and our Dr. Sergio Ramola, OBGYN, who's leader of our Washington, D.C. chapter. So thank you all very much for everything.
Thank you.
Mm-hmm.